Now, it's really always the case that clinical trials, from in a sense, an economic point of view, are never long enough. The clinical trial stops too soon. It stops too soon in the sense that not everybody's dead. In a way, what we'd really like to know is when everybody died. But of course, it's not practical to run, or probably ethical, to run the trial until everybody's dead. We specify how long the trial will last, and typically we might either have a fixed period of follow-up, or sometimes you stop the trial when more than a certain percentage have experienced a particular event. Now, there's very good reasons for this. One is to try and minimize patients' exposure to the intervention that you're trialing, because of course it may be harmful, we don't know. And so you don't want to expose too many patients if you can avoid it. More than that, trials are costly, and the longer we run the trial, the higher the cost. More than that, the reason we're doing the trial is to try and establish effectiveness in the hope that we can demonstrate this is a good treatment and introduce it so patients can get the benefits. And so there's lots of good reasons why the trial doesn't go on and on and on. And they are good reasons. But the problem it gives us is we don't know what happens to most of the patients. We know what happens to a few of them. We observe them, for example, dying. And so we need to extrapolate into the future. And this is a statistical procedure, and there's a wide choice of statistical distributions we can use to go from the observed data during the trial to predicting what happens to the patient group over time. And in the next slide, I'm going to compare two different statistical models. One is an exponential model, and the other is what's called a log-logistic model. And the key point is they produce rather different results. So they start with the same data. They start with the trial data, the observation of what happened during the trial to these patients, and then they predict what happens next. Now, this looks complicated, but it's not nearly as complicated as it looks. First of all, exponential model on this side and log-logistic on the left-hand side. Along the horizontal, we're measuring time. It's measured in terms of cycles of the model, and roughly speaking, in this model, 52 cycles is equivalent to about 5 years. So 270 cycles is in excess of 25 years. So this is quite a long time period, remembering that most of these patients, when they enter this model, are 70 to 75. That's the typical age of diagnosis. On the vertical, in both diagrams, we're measuring cumulative years gained. So this is by surviving the additional years of life that are being gained. Okay, let's take the log-logistic model first of all. We've got, ignore the dotted line just now. The two solid lines, the upper one is drawn for azacitidine, and the lower one, BSC, or best supportive care. So best supportive care is the, if patients get an infection, we treat the infection. If patients need a transfusion, we transfuse them. Azacitidine is the alternative, and that's the new treatment, the active treatment. And so what happens is we take the data from the trial, we observe what happens to these patients during the trial, and to those data points, we fit a curve. And in this case, it's a log-logistic function that's used, and that gives us this predicted accumulation of years of life. Now notice, this azacitidine curve is going up and up and up. It's leveling off a bit, but it's still increasing. That implies that patients are still alive after 25 years. They're still acquiring years of life. We can contrast that with the best supportive care, which levels off a bit sooner, and by, well, what would that be? By about 10 years, virtually everybody is dead and there's not additional years of life being gained. Okay, so those two curves, using a log-logistic model, using the data from the trial, predict for yes?
Yeah. So that comes from a trial comparing azacitidine versus best supportive care.
It does, yes.
How do you know that best supportive care gains, let's say, 1.5 years if it's not compared against no treatment at all?
Right. The cohort are accumulating years of life. So from the point of trial entry, as long as you're alive, you're gaining years of life. So the 0 point is at entry to the trial.
I see. So comparison
that's right.
Someone who dies there.
That's right. And the longer you live, the greater the accumulation of years of life.
Okay.
So compared to everybody, I mean, hypothetically it doesn't make much sense, but compared to everybody entering the trial and just dying, how many years of life are the patient group getting? So this is saying that the patient group who get best supportive care are accumulating years of life, but it's a decreasing rate. And by about 10 years, it's not really increasing, and so virtually everybody in that patient group is dead. By contrast, the azacitidine patients are still alive way out here at 20, some of them at 25 years, because the curve's going up and up. Now I stress that is starting with the observed data in the trial, but applying a particular statistical distribution to it, the log-logistic. Now the dashed or dotted line is the difference between the two curves, the vertical distance between best supportive care curve and the azacitidine curve. And the difference is increasing and increasing and continuing to increase. Now, this difference, this dotted line, is going to be the main driver of a difference in QALYs between those who get best supportive care and those who get azacitidine. We haven't allowed for the quality adjustment yet. We haven't allowed for what health state the patients are in. But a main driver of the QALYs, the QALY difference between those who get best supportive care, those who get azacitidine, these life years are going to be the main driver. Now, we can compare that in the right-hand side to an exponential model. Again, we've got a best supportive care, leveling out, if anything, a bit earlier than in the log-logistic model. And the azacitidine is also beginning to level out maybe about 10 years. And of course, the vertical distance, so the difference between years of life being accumulated between best supportive care and azacitidine, the dotted line, it's also leveling out at a much earlier stage. So we've got a really marked difference here. If you look at the area under the dashed line in the log-logistic diagram, it's quite a big area. By contrast, the area under the dashed line in the exponential model, it's quite big, but it's half the size of the log-logistic. And so, consequently, you're going to get a much larger estimate of QALYs gained with azacitidine if you use a log-logistic model. If you use an exponential model, your estimate is much smaller. Now, the manufacturer went, you won't be surprised, for log-logistic model. That was their preferred model. The committee looking at this said, actually, we find the log-logistic is implausible. Part of it is so many patients surviving into their 9th decade. These are sick patients. It's not a cure. It's a treatment that helps, but it's not a cure. Whereas with the exponential, the idea that virtually everybody is dead by 10 years seemed much more realistic. And of course, this affects cost effectiveness. The cost per QALY in the log-logistic modelling is much lower than the cost per QALY estimate you get in the exponential. So the point of this example is how you go about predicting the future, how you go about extrapolating into the future can be really important. It could lead to a difference between a yes and a no in the judgment of, is this a cost-effective use of resources? Right. So the choice of survival function, in this case log-logistic or exponential, is really important in determining the number of QALYs that the different treatments will generate. And so consequently, this is a topic that is quite an area of dispute between a manufacturer who's trying to persuade people that they have a very good product and perhaps a third-party payer who is more sceptical about the benefits, particularly in relation to the cost. Okay.